Welcome. NSG 515, Study Section 2, Principles and Assessment Criteria in Intensive Care. In this study section, you will be discussing the principles and assessment criteria in intensive care. You will begin with an explanation of what intensive care unit means. You will move on by highlighting the different principles that govern the conduct of activities in the intensive care unit. Subsequently, you will discuss the admission and discharge criteria. Moving on, you will describe how assessment is carried out in intensive care units, under which you will examine the general assessment, neurologic assessment, respiratory assessment, cardiovascular assessment, gastrointestinal assessment, and renal assessment. Other types of assessments were also briefly discussed. Learning outcomes. When you have studied this section, you should be able to define intensive care units, highlight how assessment is carried out in the ICU. Intensive care units. Have you ever been to the intensive care unit of a hospital? Can you share your experience? An intensive care unit, ICU, also known as intensive therapy units or intensive treatment unit, ITU, or critical care unit, CCU, is a special department of a hospital or healthcare facility that provides intensive treatment medicine. Intensive care units cater to patients with severe and life-threatening illness and injuries, which requires constant, close monitoring and support from specialist equipment and medications in order to ensure normal bodily functions. They are staffed by highly trained doctors and nurses who specialize in caring for critically ill patients. ICUs are also distinguished from normal hospital wards by a higher staff-to-patient ratio and access to advanced medical resources and equipment that is not routinely available elsewhere. Common conditions that are treated within ICUs include ARDS, trauma, multiple organ failure, and sepsis. Patients may be transferred directly to an intensive care unit from an emergency department if required, or from a ward if they rapidly deteriorate, or immediately after surgery if the surgery is very invasive and the patient is at risk of complications. Principles of intensive care. In order to understand the principles of intensive care, there is need to first explain the two terms differently. You must have heard the word principle a lot of times, but do you really know what it means? The word principle means an important underlying law or assumption required in a system of thought or a standard of moral or ethical decision making. The word intensive implies a concentration of efforts. Intensive care nursing is a comprehensive, specialized, and individualized nursing care service which is rendered to patients with life-threatening conditions and their families. According to Shuva DG 2005, the principles are listed below. 1. Anticipation. 2. Early detection and prompt action. 3. Collaborative practice. 4. Communication. 5. Prevention of infection. 6. Crisis intervention and stress reduction. Admission criteria. ICU admission criteria should select patients who are likely to benefit from ICU care. The ICU admission decision may be based on several models utilizing prioritization, diagnosis, and objective parameters models. These models are presented as guidelines, and individual institution must create specific criteria to meet their special requirements. Prioritization model. This system defines the benefit of ICU from priority 1 to priority 4. The people that will benefit most from the ICU, priority 1, to the people that will not benefit at all, priority 4, from ICU admission. In order to understand this better, read the article that follows. Diagnosis model. This model uses specific conditions, diseases to determine appropriateness of ICU admission. Cardiac system, pulmonary system, neurologic disorders, status epilepticus, drug injection and drug overdose, gastrointestinal disorders, endocrine system, surgical, miscellaneous. Objective parameters model, vital signs, laboratory values, radiography, ultrasonography or tomography, electrocardiogram, physical findings, acute onset. Discharge criteria. The status of patient admitted to an ICU should be revised continuously to identify patients who may no longer need ICU care. When the patient's physiologic status are stabilized and the need for ICU monitoring and care is no longer necessary. When a patient's physiological status has deteriorated and active interventions are no longer planned, discharge to a lower level of care is appropriate. Discharge criteria should be similar to the admitting criteria for the next level of care, such as intermediate care where available. However, not all patients require intermediate care after ICU discharge. The following are discharge criteria from the ICU. Underlying condition improved or resolved. Benefits of monitoring in an ICU considered small. Patients with acute respiratory failure, extubated and does not require assisted ventilation and in stable condition after observation for period appropriate to his or her condition. Patient with shock in stable cardiovascular condition. Condition beyond salvage and might not benefit from intensive treatment in ICU. For patients in stable condition requiring long-time ventilatory support, they should be discharged to and managed in the assisted ventilated ward instead of ICU. The discharge is decided by agreement between the patient's doctor, patient's family members, and the nurse in charge, conducted according to guidelines as stipulated above. Assessment in intensive care. When a patient is in an intensive care unit, what are the yardsticks you use in carrying out a proper monitoring? You should know that if monitoring is not effective, it may lead to a lot of damage, which may even result in death. In order to avoid this, what are the things you should watch out for in an ICU patient? Below are mnemonic to assist in the tasks of assessments. General assessments. Address the patient by name, even if the patient is unconscious, and explain what you are going to do. The initial routine inspection includes rapid assessment of the airway, breathing, and circulation. Once you are happy that the patient is ABC stable, you can proceed to the more detailed physical examination. Neurologic assessments. Level of consciousness is usually monitored by the Glasgow Coma Scale, GCS, making sure to compare with the client's GCS trends. Reflexes such as pupil size and reaction to light, corny reflex, gag reflex, and respiration pattern will give an indication of brainstem function. Respiratory assessment. Always assess the adequacy of the airway, even if the patient has an endotracheal tube in place. It may be kinged or blocked. Assess oxygenation in terms of pulse oximetry, breathing rates, the tidal volume, the respiratory effort, and if ventilated, the positive end respiratory pressure, PEP. Look for asymmetry of chest movement and position of the mediastinum as judged by the trachea and apex beats. Cardiovascular assessments. It is important not to overlook simple vital signs such as blood pressure, pulse rate, and rhythm, urine output, and peripheral perfusion. Information may also be available for cardiac output, peripheral resistance, oxygen delivery and consumption, and other estimates of cardiac function derived from echocardiography. Assess peripheral pulses and auscultate the apex beat for added sounds, murmurs, and bruits. Gastrointestinal assessment. Carefully inspect the face for signs of sinusitis and the nose and mouth, especially in the presence of artificial airways and tubes, as they can make thorough inspection difficult. The abdomen should be observed for distension, wounds, and drains. Palpate for tenderness, tenseness and abnormal masses, listening for bowel sounds, and inquire about bowel actions and absorption of oral feeds. Renal assessments. Note the adequacy of intravascular volume as reflected by the pulse rate, peripheral perfusion, urine output, central venous pressure (CVP), and note the state of hydration, e.g., skin, sugar, tongue. Street intake and outcome monitoring urinalysis should be done. Check electrolytes, sodium, potassium, calcium, phosphate, and magnesium, urea, and creatinine as markers of renal function. The urinary catheter is accessed to check for signs of infection. Other assessments. Limbs should be carefully inspected for rashes, oedema, and adequacy of perfusion. Hands, feet, and nails should also be inspected. Blood glucose should be adequately controlled, as evidence shows that the tight control of blood glucose to within normal level improves mortality in the ICU. Check for obvious oozing or bleeding. Note the results of coagulation tests, platelet counts, hemoglobin level, and white blood cell counts. Thromboembolism should be prevented by ensuring frequent turning, mobilization, graded compression shockings, anticoagulant therapy where appropriate. Client's medication should be reviewed and signs of adverse reaction should be watched out for. Psychological support is given to the clients and the relatives to relieve the fears and anxieties that they might have. Unless sitting up is contraindicated, patients in intensive care should always be sat up to angle of at least 30 degrees. Study section summary. From our discussion on the intensive care units, we discovered that the intensive care units can provide efficient and effective care to the critically ill patients by implementing well-thought-out admission, discharge, and triage policies and procedures. Intensive care practice has commendably been accompanied by continual evaluation of results of therapy and a constant search for improved method of selection of patients likely to benefit from intensive therapy. A mnemonic to assist the healthcare personnel in the tasks of assessment is listed below. A. Airway. B. Breathing. C. Circulation. D. Disability. G. CLs and focal neurology. E. Electrolytes. Results. F. Fluids. Are they appropriate? G. Guts. Examine and nutritional assessment. H. Hematology. Results. I. Infection. Latest micrology and white cell counts. L. Lines. Are the sites clean? How long have they been in? M. Medications. Review and interaction. R. Relatives. What is the common message? End of study section 2. Thank you.